Thanks, Dilip, and thanks to the organisers for the invitation. I'm starting on the premise that some people with subcutaneous infections and deeper-seated infections will require intravenous antibiotics, and this is a big burden for us in hospitals. They're spread throughout our hospitals. In fact, surveys that have been done have suggested 1 in 10 hospitalised patients on any one particular day would require intravenous therapy, and about 16% of these are people with complex skin and soft tissue infections. And what some of them have in common is that if they didn't require the intravenous therapy, they wouldn't require to be in hospital. So that's the sort of starting point, and the point that introduces us to outpatient parenteral antibiotic therapy, which many of you will already be familiar with, but essentially it's about managing patients without an overnight hospital stay with parenteral therapy, more traditionally associated with hospitalization. And of course, we take it for red, all the issues about antimicrobial stewardship. These are people that require intravenous therapy. They've been properly assessed. There's no appropriate oral agent available. But the IV therapy does assure absorption, compliance, and rapid achievement of therapeutic concentrations. And there's a lot of data to support it in skin and soft tissue infection, including wound infections and various other infections, including diabetic foot infections. And of course, there are lots of advantages to outpatient management of serious infections. Quality of life may be improved, including sleep, privacy, nutrition, mental health, increase in education and training in self-care, cheaper for the patient often and for the relatives visiting hospital, and reduced risk of complicating infections and antimicrobial resistant infections. And of course, there are major organizational benefits. This is a graph just really showing the sort of the bulk of hospitalized patients require relatively short stays, and these are the sort of patients that we need to be aiming for ambulatory care, and a lot of soft tissue infection patients and infected ulcer-type patients might fall into this category. But essentially, OPAT is the means through which admission can be avoided or shortened, and it allows for a more effective use of resources, lower rates of healthcare-associated infections, and in fact can also help manage healthcare-associated infections. And for us in the UK, certainly, it's been a huge lever to introduce specialist infection specialist management of many infections that ordinarily we wouldn't have had such a scope to get involved with. Here are some wounds. These are just data from Scotland in 2006, showing about a 10% rate of healthcare-associated infections in all hospitalized patients, and a fair number of these were infected wounds, as you can see, as skin grafts, abdominal wounds, post-cabbage grafting sites. And healthcare-associated infection contributes to about a 70% increase in length of stay, 500,000 extra bed days a year in Scotland, which amounts to about £183 million. So an awful costly thing, which OPAT can contribute to. Now, what's the evidence? Well, there's quite a lot of evidence. Professor Lipsky will know that OPAT's been around in the United States since the 1980s. It's a standard part of practice. It's been a standard part of practice in the Southern Hemisphere since the 1990s, and an emergent form of therapy in Europe since the 1990s. We've got standards for giving IV therapy. Those of you that are nurses will be well familiar with the Royal College of Nursing standards if you're in the UK. We've got disease-specific guidance from the IDSA for endocarditis. In the UK, we've developed patient group directions, which allow for a nurse-led management of skin and soft tissue infections. We've got very limited randomized controlled trial data, but where we do have it, it's for skin and soft tissue infections. But interesting, a lot of the new antimicrobial evaluations do include, and in fact, allow for the inclusion of patients managed in the outpatient setting. This is just one particular study of Staph aureus bacteremia, where more than half of the participants were actually managed at least part in an outpatient setting. This is our Glasgow OPAT clinic. It's a rather traditional OPAT clinic led by an ID physician with the input of an antimicrobial pharmacist. We have weekly virtual ward rounds, so we don't have to see everybody all the time. And I have a weekly medical clinic for this. The red box is to signify the central essential role of the nurse specialist, who's really the real focus and expertise within delivering outpatient parenteral therapy. So all their roles are there: vetting, assessment, education, training patients and relatives in administration of antibiotics, coordinating the intravenous lines, the logistics, and critically communication, coordination, and clinical linking. And also, from our point of view, maintaining our prospectively maintained database. Just a quick overview of our OPAT service. This is 10 years worth of data. You can see that more than 50% of the patients in our service, skin and soft tissue infection, but a relatively smaller proportion of them, a smaller proportion of overall duration of IV therapy. So shorter courses of IV therapy, and this is something we're very strong on, is to promote rapid IV to oral switch in the OPAT setting. So here's some typical skin and soft tissue infections. I think none of these patients, any of us in the room, would say need topical engineered honey or acetic acid to manage their infections. These are all patients that require systemic antibiotic therapy. These are serious infections, but all amenable to outpatient therapy. So these infections that we manage in the outpatient setting need to be non-life-threatening. They need to be non-immediately severe, without sepsis, not rapidly progressing, don't require to be in hospital for other reasons, and they should have a predictable response to antimicrobial therapy. Their comorbidity should be predictable or stable, and they should have a suitable home environment, psychological circumstances. And OPAT really gives us a potential to avoid admission in this population. But as we've heard already, I think by many of the previous speakers, and particularly in our first session, we need to be sure what we're treating. Matt showed the red leg thing. Don't treat soft tissue redness or inflammation. Treat the infection. Be wary of underlying deep-seated infection. This was a skin graft with an underlying tibial fracture and an infected plate that needed to be removed before the skin infection could be cured. And this was an intra-abdominal wound infection that couldn't be cured because there were a whole bunch of swabs left in, which were a nidus for infection. So be careful what's going on underneath, and be aware that you need to think beyond the skin. And critically, OPAT, but antibiotics in every way are not an alternative to source control. But I think you know that, and we've heard that from our other speakers. These are just some of our diabetic foot patients that we've managed in our OPAT clinic. And this is some follow-up data of all our bone and joint infections, just over a couple of years of follow-up. And you can see what stands out in our experience is that our diabetic foot osteomyelitis patients, many of whom, or the majority of whom, present with ulcers, even with a prolonged course of intravenous followed by oral therapy, don't do well long-term. And I think this probably stands out with many diabetic foot case series, but do pretty badly compared to the other bone and joint infection patient groups. If we think about skin and soft tissue infections, in particular, our criteria for selecting patients for outpatient therapy, they should require IV therapy, they shouldn't need surgery immediately, they may or may not have a healthcare-associated infection, and they should have the stable comorbidity. If so, we can think about them for OPAT, but if they're in the OPAT setting, they may require further investigation. We may need to think about further radiology, particularly for exclusion of bone and joint infection, further assessment from specialists, and they may need other specialist follow-up. So it's not the end of the road just getting onto OPAT. We need to be thinking dynamically about their antibiotics, but also dynamically about their other aspects of care. We use a range of different antibiotics in OPAT, but you can see in the UK, very much we use quite a lot of ceftriaxone, which we have more or less banned from our hospitals because of the association with Clostridium difficile and the association with antimicrobial resistance amongst our gram-negatives. But we're using it fairly safely in our outpatient setting. And our other alternative is teicoplanin, but a whole range of others can be used. But we have to think about efficacy for the treatment for the infection that we're treating, safety for the patient, drug interactions are important, spectrum of antibiotics, and ease of administration. I'll tell you a little bit about the patient group direction that we developed in Glasgow. We identified patients with skin and soft tissue infections as a group with a non-life-threatening skin and soft tissue infection that was amenable for home care but required IV therapy. We developed a uniform therapeutic management for this patient group. We developed a protocol. We trained up our specialist nurses who very rapidly became experts in management. We had a suitable protocol including exclusions. They had to be reviewed by a doctor at least once at the beginning. And it was locally approved. But this was built on a kind of national legislative framework in the United Kingdom for a whole number of different potential conditions, but we really developed the first patient group direction for skin and soft tissue infection. And this is just a little bit about the evaluation of it. One of the main questions we asked back when we started doing this in about 2002, MRSA was rife, as you've heard, about 40% in Scotland. Did our patients have a history of MRSA, or did they have a beta-lactam allergy? If so, they would be go on to ticaplanin followed by clindamycin. If not, they would get ceftriaxone followed by clindamycin or flucloxacillin. And critically, our nurses would follow these patients with skin and soft tissue infections up every day. And when they were suitable to switch, if they had reduction in heat, erythema, and induration, they would switch to oral therapy. And so we implemented this and we followed it up. And what we found was that before we introduced our patient group direction, cure rate was good, 99 versus 97 following the introduction of this protocol. Following the introduction of the protocol, the medical review plummeted, so we were being called to see many less patients because, as I said, our nurses had become expert at managing this condition. And interestingly, when we followed this up over time, what we've observed is in the beginning, pre-patient group direction days, we were using longer durations of IV therapy. And then just to our follow-up point, our median duration is about 3 days. So using our nurses within our OPAT setting as antimicrobial stewards, promoting IV to oral switch efficiently, really doing exactly what we've been hearing about. What we want to do is to limit use of antibiotics, so by developing their expertise in this area. Just some other data that we gathered just to show you that women more likely to fail on outpatient therapy, diabetics who have all sorts of problems with compliance with therapy, wound healing, et cetera, more likely to fail on outpatient therapy. And the other thing, along with many other observations with glycopeptides, we found that glycopeptide therapy with ticaplanin less effective than beta-lactams, much more cidal antibiotics. And the other thing of interest to you is that we found that wound infections within this sort of cohort of patients with skin and soft tissue infections required longer therapy, as did patients with MRSA, vascular disease, and other kinds of non-cellulitic skin infections. Just overall, I don't know how many of you are involved in OPAT or are familiar with it, but this is some longer-term outcome data from our population, a sort of review of 10 years worth of data. Very low rates of line-related infections and other line-related complications, low rates of venous thromboembolism, Clostridium difficile, which when we started all this was very, very prevalent in our hospitals, very, very rare, almost unheard of in our outpatient setting. Adverse drug reactions you have to be aware of, but relatively low prevalence of 6.7%. And unplanned readmission, relatively rare, but something you have to be very much aware of. A little bit about the changing landscape of OPAT in the UK. So we've had an explosion of OPAT in the United Kingdom over the last 5 to 10 years. And we've gone from being very much Dilip Nathwani and Andrew Seaton preaching about OPAT as being an ID physician-led service to being very much an ID specialist-led with microbiologists, clinical pharmacy specialists in antimicrobials, as well as ID physicians. We've also had an explosion in ambulatory care, as we've seen in other parts of the world. A lot of infections being managed by emergency medicine and acute medicine, and also an explosion in interest with our community teams, general practitioners, and many developing community-led teams by specialist nurses, and also private contractors, a relative rarity in the UK, but now starting to come in. What is clear from all of the developments that have happened is this, again, this red box, this central role of the nurse specialist in outpatient parenteral antibiotic therapy. I've again highlighted the importance of ambulatory care, because ambulatory care is happening with all sorts of things. On all this kind of background, we've got major differences we're observing in regional governance and also funding. In fact, we have 4 different healthcare systems in the United Kingdom. And even within regions of the or within countries in the United Kingdom, we have different funding processes for OPAT. And clearly by 2009, we had no national strategy how to manage this monster that was OPAT. This graph here just shows you numbers of OPAT teams that we were aware of back in '99 in our first survey we did, 2011. And this is just an estimate, a guesstimate really, of how many we have in the UK now. It's probably many more than that. And as well as having many different kinds of OPAT services, it's all being done in different ways, in ambulatory care or intermediate care setting, NHS clinics, in home, and then in a clinic by an NHS provider. And then OPAT is actually just a small slither of outpatient IV therapy. And you can see that this was a survey we did just very recently around the UK of emergency departments, and it's been delivered in all sorts of different ways. In many ways, quite separate from mainstream infection-led services. So this brings me on in my final minute really to tell you about BSAC initiatives. In 2009, BSAC recognized the aims and challenges of all the things that I've been telling you about and tried to put together some kind of key issues related to delivering a safe OPAT throughout the United Kingdom. So developing a national forum and resource center with a website at eopat.com. Please go there and you'll find all our resources. Organizing national, international conferences, symposia, national workshops. We've set up and developed a business case toolkit to allow people to develop their own services in the way in which we would like to promote. And also work done to try and streamline funding. And also critically, and probably most importantly, BSAC has also developed good practice recommendations for adults, and now this year for children, and a very recent paper on development of stewardship within the OPAT setting. So covering really all the major clinical governance areas that you can think of in OPAT. I've not got time to go through this, but just to say, read the good practice recommendations, and a lot of it hopefully would translate to practice that you would understand. And then really just to show you, to acknowledge the work of Mark Gilchrist, who's been really driving the development of a patient management system to try and uniform the way we collect data and also look at data nationally, developing this into a patient registry, both for the United Kingdom and also thinking more broadly, potentially internationally. Ongoing work is about antimicrobial stability and infusion devices, and again, antimicrobial stewardship, and making sure that we don't have this explosion of services where antibiotics are overused. And we're cognizant of the principles of antimicrobial stewardship that you've heard about. And we want to really establish and acknowledge that OPAT now is a robust standard of care. So in conclusion, I hope I've shown in that whistle-stop tour that OPAT is a safe and effective for a variety of different infections in carefully selected patients, primarily for today for skin and soft tissue infections, including wound infection, but IV antibiotics in general and in OPAT in particular are not a substitute for proper clinical management and source control. We've had a massive increase in OPAT and OPAT-like services in the UK, and it's really important that we look at our clinical practice and make sure we've got good, robust clinical governance frameworks and that we underpin this with good, solid antimicrobial stewardship principles. And just very finally, I just acknowledge my colleagues in Glasgow, Dilip Nathwani, of course, who started up the whole OPAT BSAC development back in 2009, and Mark Gilchrist here, who is the co-chair of the OPAT initiative with myself at the moment. So thank you very much for your attention.